Welcome to an overview of Accutane, or isotretinoin. Accutane, the branded name, is no longer available on the market, but other brands are available: Absorbica, Amnestine, Clavaris, Miracin, Sortra, Zinatane, and then the newest Absorbica LD, or low dose. Background information. Isotretinoin, or the retinoids, are synthetic and natural compounds that have biologic activity similar to vitamin A. Vitamin A deficiencies induce various changes in the skin, such as epidermal hyperkeratosis, squamous metaplasia of the mucous membranes, and various keratinization disorders and precancerous conditions. In 1943, vitamin A was first used for the treatment of acne. Development of isotretinoin started in the 1970s and was FDA approved for the treatment of acne in 1982. The current indications by the FDA are for acne vulgaris, but it's also used off-label for some various different issues, such as follicular disorders, acne-related conditions, rosacea, hidradenitis suppurativa, dissecting cellulitis of the scalp, disorders of keratinization such as Derriere's disease, pityriasis rubra-pilaris, ichthyosis, and keratodermas. Other inflammatory disorders such as lupus and lichen planus, less commonly used but still options. How does isotretinoin work? It's not 100% understood how isotretinoin is working for acne. We do know that there's normalization of the keratinocytes, and that normalization prevents the follicular plugging that we'll see as the fundamental issue with acne. We also know that it shrinks the oil glands, so it does take away that breeding ground for the P. acnes bacteria by shrinking the oil glands. That shrinking of the oil glands and normalization of the keratinocytes has a potential to help to repair as well as prevent the acne from forming. We cannot consider Accutane a cure for acne, but we do tend to see very dramatic results, oftentimes to the point that people don't need anything afterwards after they completed a course. Sometimes we do have to do a second course. Rarely do we do third courses, but on occasion. Generally, patients are either clear or we can maintain with topical treatment after a course of Accutane. In general, the prescribing methods, there's no right or wrong. There's lots of different ways that this medication is used. Most providers within KMC follow a low dose for the first month and then increase base by weight for 4 to 5 months. This treatment plan, I like it because the low dose treatment for the first month helps to prevent some flares. Some patients might be concerned that their skin's going to get worse before it gets better. Although patients still can flare with this dosing regimen, it is less common when utilized this way. Some providers might do a low dose until clear. This is utilized for in situation where we want to avoid the dryness aspect or the side effects of the medication. There's weight-based dosing, so maybe they would start out at the 0.5 to 1 milligram per kilogram per day and do that for 15 to 20 weeks. Some skin disorders may require long-term low dose. Rarely for acne, but yes, on occasion we might do long-term low dose treatment. In general, though, it's going to be 0.5 to 1 milligrams per kilogram per day for 15 to 20 weeks to a cumulative dose of 120 to 150 milligrams per kilogram. Side effects. Every medication has its pros and cons. With this one, there are 2 expected side effects. Number 1, it's going to make the skin sun sensitive. All sun-exposed areas need to be protected from the sun. Make sure we're wearing sunscreen, reapplying every 2 hours for the best benefit. Not my favorite medication to be prescribing in the summertime for lifeguards or people that are outside all the time, but it can be done if they're going to follow proper skin sun protection. Second expected side effect is that it is going to make the mucous membranes and skin dry. That might manifest itself as dry lips most commonly. This can be managed with any chapstick. My favorites are Aquaphor or Vaseline or Dr. Dan's Cortibon multiple times a day. We might notice some nosebleeds due to the dryness, especially in the winter time. Eyes could become dry. Any lubricating eye drops, saline nasal sprays for the nose, running a humidifier in the winter time, and then good skin hydration for the overall dry skin. Somebody that's prone to eczema is likely going to flare while they're on this medication, and we may also need to add in some topical steroids along with good skin hydration while we're on this medication. This does normalize, usually takes about 2 weeks after they come off the medication, but things will tend to get back to normal. Unexpected side effects. Unexpected side effects associated with the skin and hair. Rarely, we might see some telogen effluvium or hair loss. With the skin, rarely some pyogenic granulomas, especially around the toenails, that might require lowering the dosage if we're not able to control that with some topical antibiotics. The skin may be more fragile. They might feel like they just a sheer force could be enough to damage or break the skin. And a lot of patients will notice that their skin just feels different. It just kind of feels almost like a waxy feel or a tacky feel to the skin. Ocular changes, in addition to the dryness, there is a potential for a decrease in night vision associated with the medication. Generally, this will resolve after they come off of the medication. Neurologic issues. Biggest concern is pseudotumor cerebri, or a false swelling of the brain. This is likely to occur due to a known drug interaction between tetracycline-based antibiotics and the isotretinoin. Both of these medications are known to have this as a potential side effect. They should not be prescribed together. Personally, I like for my patients to have approximately a 2-week washout period between their tetracycline-based antibiotics and the start of isotretinoin. Not every provider does this. It's a personal preference. A lot of providers will, day 1, stop the tetracycline-based antibiotic, day 2, start the isotretinoin. There's no hard and fast rule with this. Psychiatric issues may manifest as depression, potentially even suicidal ideation. There's quite a bit of literature supporting the fact that isotretinoin in and of itself likely may not result in the depression, although this is seen during treatment. It may also be related to the acne in and of itself. Some studies will show that mood improves, and that's what I feel like I see in practice, is that you have a patient that comes in and they're covering their face, they're not looking at you in the eye due to their severe acne, and we get to see a different person at the end of treatment because they have more confidence, their skin is clear, they see the improvement, and it's very rewarding to see those changes. But we do have to monitor monthly for potential for depression, suicidal thoughts, and if those things are happening, we need to get the patients off the medication. If they have a history of issues with depression or suicidal thoughts, we need to make sure that we are conversing with their psychiatrist or counselor and making sure that they feel like they're stable before we were to start them on this medication. Arthralgias and myalgias, muscle joint aches. This is one of the more common unexpected side effects. Generally about 13% of patients might experience this. We can usually work through this with ibuprofen. I stay away from Tylenol while we're on this medication because it's filtered through the liver. Ibuprofen though, most people, we can work through it. They don't tend to want to come off of the medication because of this potential side effect. Bone changes. There is a potential risk for premature closure of the growth plates But we don't tend to see that happen for acne treatment because it's a low dose, short treatment plans. We might be more concerned about this in some of our long-term treatments for the ichthyosis or some of the disorders of keratinization if we had a patient that was really young that's on it for a longer period of time. But in general, with acne treatment, it's not as big of a concern. Lipid changes. This medication can elevate triglycerides or cholesterol. If triglycerides tend to get too high, we could induce a pancreatitis. I start to get concerned about lipids once they're reaching about the 300 level. At that point, I'm going to start intervening with fish oil. And if that's not beneficial, if we're getting up into 400, 500s, then we might add in statins. Beyond 600, we're coming off the medication. It's just not safe for them after that point. Gastrointestinal issues. We do pre-screen for any history of irritable bowel disease, Crohn's disease, or ulcerative colitis. There's a theoretical risk between irritable bowel disease, Crohn's disease, ulcerative colitis, and Accutane. The theoretical risk is that as we dry out the skin, are we drying out the gut, maybe predisposing changes in the gut to these disorders. But we don't see an increase in these issues in the Accutane treated population versus the non-Accutane treated population. So we just want to be aware and careful. And of course, if patients were to develop any bloody stools while they're on this medication, then we would want to definitely come off of it. This medication is filtered through the liver, as is alcohol, so they should be avoiding alcohol while they're on this medication. Tylenol as well, which is available over the counter to minimize risk for elevated liver enzymes. Hematologic issues. This medication rarely will result in leukopenia or agranulocytosis. I have only encountered this one time over the last 18 years. So it's really rare, but it is a potential side effect. Teratogenetic. This medication is a pregnancy category X, and that's where all the issues with this medication come from. We must prevent pregnancy while our patients are on this medication. So therefore, we have the iPledge program that we're going to talk about in a moment, which is our pregnancy prevention program related to this medication. Before we get to that though, let's review some lab monitoring. Lab monitoring with this medication, there's some general guidelines. For the most part, we are all going to do baseline lab work, usually a CBC, a comprehensive panel, and a lipid panel, fasting. And then monthly lab work, this is more optional and going to be provider dependent. Some might check it for the first few months, some might check it monthly. There's no hard or fast rule as to what we need to do as far as the fasting lab work throughout the month. Females, though, do have to have a pregnancy test that can be done either by urine or by blood on a monthly basis. This is where you need to know your provider. Timing only matters for the HCG, so you need to know, is your provider going to be doing the HCG via the blood work, or are they going to do it via the urine pregnancy test in the office? And that's going to help you determine to know when your patient's going to get their lab work done. We will want our patients to be fasting for the lipid panel to get good results. Now let's talk about the iPledge program. The iPledge program is the National Registry for Pregnancy Prevention. All patients, providers, and pharmacies have to be registered in the iPledge program in order to prescribe or dispense the medication. As you can see, there are two booklets, one for males or females that can't get pregnant. That one's blue. There's one for females who can get pregnant, and that one's pink. Let's talk about the male patient first. What you're going to need to get a male patient or a female that cannot get pregnant, so that would be somebody that has had a hysterectomy, or they are postmenopausal. You're going to need the booklet. You're going to need the registration information, the last four of the Social Security number. If we don't have the last four of the Social Security, or they are not willing to provide that to us, we can contact the iPledge program and get an override code for the last four of the Social. We will need the patient to read through and sign the consent form, and then we'll also need the patient's ID number. Males and females that cannot get pregnant are really very easy within the iPledge program. Don't get confused with these. What's nice is that we're going to be able to re-register them at any time. So the timing issues that we think about with the iPledge program are not a problem with the male patients and the females who cannot get pregnant. So with these patients, they're going to have monthly office visits. Every month, we're going to counsel them not to donate blood while they're on this medication, not to share their medication with anybody. We're going to send in their prescription. We're going to confirm them in the iPledge program that we believe that they understand the importance of this pregnancy prevention program, that they can follow the rules, and that they're not going to do any of the things that are in the counseling. If by chance they fall out of their prescription time frame, meaning they were lost to follow-up, we can re-register them at any time. So do not be concerned about a 7-day window with the male patients, or that it's been over 53 days that they've come in. All of this is not important with the male patients. Female patients of childbearing potential, this is where things get confusing, and this is where we must be the experts with this medication. What you're going to need, you're going to need the registration information, the last four of their Social, 2 signed consent forms that are in the iPledge booklet. There's one for the pregnancy prevention, and then there's one that's more the general form, similar to what's in the mail packet. You'll need the patient's ID number, their 2 forms of birth control, and then the first HCG. Once we have all this information, then we can register them in the iPledge program, and this will open a 30-day waiting period. Now, what's important about this is that the 30-day waiting period starts from the date of registration, not the date that we do the HCG. Therefore, what will sometimes happen is that a new person within KMC may not realize that they have to register this patient, and they come back a month later to start the medication, and they weren't registered. Unfortunately, their 30-day window never opened, so we get to start over again and wait another 30 days. It is extremely important that this is done on the day that we get the HCG, the date that we have all the information, so that the patient knows when their 30-day window is opened. Do not, if this is at the end of the day on a Friday, wait until Monday to get the patient registered because you wanted to leave. It must be done before you go home that day. Now that the 30-day waiting period is open, what next? We're going to have to determine when the patient is going to follow up and when they're going to do their second HCG, 30 days apart. This is where, once again, you need to know your provider's preference. The next HCG is going to be 30 days or longer from the date of registration. So, is your provider going to include that with the baseline lab work on the lab slip? If this is the case, then you will write the date on the lab slip for the patient to do the lab on or after 30 days from the date that they got registered. If the provider is going to do urine pregnancy tests in the office, then you need to make sure the patient is scheduled 30 days or longer from the date of registration, and then give them a lab slip for the baseline lab work. And they will be able to do that lab work fasting at their convenience at least 2 to 3 days before the appointment. In that situation, then we'll have the lab work back so we can review that at the time of visit. When the patient returns 30 days later, that is their start day. At this point, we will repeat a pregnancy test. We will have 2 negative pregnancy tests 30 days apart. We will review their 2 forms of birth control. Ideally, we want to start this medication during the first 5 days of the menstrual cycle. Now, this is one thing that I have it starred because not everybody has regular menstrual cycles. So if you are irregular in your menstrual cycle or you have an IUD and you don't have menstrual cycles, well, then we just have to do 30 days apart. Sometimes it can get extremely confusing as to when is that first 5 days of the menstrual cycle. There are a number of providers within KMC that will simply do the 30 days apart and not necessarily be too concerned about this 5 days during the menstrual cycle. But for best practice, it should be during the first 5 days of the menstrual cycle. And then we're going to counsel the patient, avoid blood donation, don't share medications, don't get pregnant. We will confirm the patient in iPledge and send the prescription. At this point, the patient now has a 7-day window, and they will need to go into the iPledge program and enter their 2 forms of birth control and answer the pregnancy prevention questions. And they will need to pick up their medication within 7 days. During this first month, it is extremely important that they do not fall out of that 7-day window. If they fall out of the 7-day window during the first month of treatment, then they have to wait another 30 days before we can reconfirm them in the iPledge program. This is only during the first month. Any other month we can repeat a pregnancy test and open it up again, but during the first month they must follow the rules. So what should females of childbearing potential expect? Monthly office visits, a pregnancy test every 30 days or longer, monthly counseling, 2 forms of birth control while they're taking the medication and for 1 month after the last dose, avoid blood donation while they're taking the medication and for 1 month after the last dose, do not share medication, do not get pregnant. Medication must be picked up within 7 days of the pregnancy test. Once again, after the first month, if the patient falls out of the 7-day window, the HCG can be repeated and a new 7-day window open, but that's only in subsequent months. Once again, you need to know your provider's preference. Are they going to do the urine HCGs in the office? If so, schedule the office visits 30 days or longer. Fasting lab work done 2 to 3 days before follow-up. Or is the HCG going to be part of the lab work? In this situation, make sure the patient knows when the next date to do lab is. What is going to be 30 days or longer from their last HCG, and then schedule an appointment, ideally as close to that time frame as possible. Personally, I have to utilize both of these methods. One office I'm in, I'm only there once a month, and it's not going to fall at 30 days for my patients, so they must do it with their lab work. In one of my other offices, I'm there more often, so we can schedule that 30 days apart. So once again, you have to know your provider's preference, and it's the HCG timing that is important. So is it in the office or is it on the lab work? At the conclusion of treatment with the female patients, we have to enter a pregnancy test after the last dose as well as 1 month later. Once we are at that point that they've completed the medication, we know what their last dose is, we're entering that final pregnancy test, we want to discontinue them at that time, not confirm patient counseling in the iPledge program. We're going to have them continue to avoid blood donation for at least a month after the last dose, and remind them not to share any remaining medication. Encourage them to have that disposed of at appropriate pharmacy receptacle, and then continue those 2 forms of birth control for 1 month after the last dose. We'll have them do another final pregnancy test 30 days post-treatment. Pitfalls of the iPledge program. Number 1, the patient did not get registered on the day of the first pregnancy test was done. So this was a scenario that I described earlier where we didn't realize that we needed to register that patient, and they went the entire month. They came back to the office thinking that they were going to get started, and guess what? They weren't registered. We don't want to see this happen. This is very disappointing for the patient as well as the provider. So must be registered the date that we get the pregnancy test in the office, sign the consent forms. Another thing that we can do as a checks and balance for this, encourage the patient to watch for that email that they'll get from the iPledge program or notification in the mail. And if they've not gotten that within a week, that might be an indication that they do not have, or that they are not registered. Another pitfall that will happen is that sometimes the local pharmacy does not have this medication on the shelf and they have to order it in. So we send in the medication and the patient doesn't decide to go get it until it's the 6th day, and the pharmacy doesn't actually have it. They have to order it. It takes 24 hours for it to come in, and then guess what? They are out of their 7-day window. This is not the patient's fault. This is not our fault. Unfortunately, we have to repeat a pregnancy test and open the window again, or if it's the first month, they get to wait another 30 days. So if we're using a pharmacy that we don't commonly use for this medication, we may want to contact them and make sure that they have the medication on the shelf and that they're going to get it. Or if there's a prior authorization that needs to be done, that we are doing that in a very timely manner. Another issue, this is probably a little bit more common, is that the patient got that HCG done too soon. Maybe it's just a day or two too early. We have to just wait a couple days and repeat it. Always watch, especially if we're getting blood draws, watch for the collection date. You have to use the collection date, not the date received, which would probably be a day or two later sometimes. One of the less common issues that will come up, but it does happen on occasion, is that the patient will, maybe over Christmas break, we have a college student and they went home over Christmas break, and then they come back and they think that they're going to continue on their treatment. And then we find out that they were dropped, they were lost to follow-up. Okay, when does this happen? If somebody gets lost to follow-up, then they have to be re-registered. For the boys, no problem, we just re-register them. For the girls, though, that's going to start another 30-day waiting period. So this is going to happen if they were initially registered and then they didn't do anything for over 90 days. And then the second situation, which is more common, is when that college student is gone over Christmas break or spring, something that is an extended period of time, and the patient was in the requires confirmation status for longer than 53 days, then they're going to follow into the lost to follow up. So these are just things that if we can avoid these situations, our patients are happier, the providers are happier, and knowing these issues could come up, make you a better helper for your providers. So ultimately, thank you for listening. I know this is a long discussion, but once again, we're the experts with this medication. We've got to know it inside and out. Have a wonderful day.